about 2 times, please. And he's had numerous consults, pediatric orthopedist, he had a pediatrician, has seen several pediatricians, was hospitalized for a brief period of time, has had x-rays and CAT scans, and you've seen a physical therapist, and who else? Who am I missing? Oh yeah, you also saw the athletic trainer. Okay, so that's helpful. Can you come and lie down, please?
Yes. Stomach or back?
On your back, please.
Okay.
Keep going. Okay. We'll keep filming. Straight leg raising reproduces his back pain at about 45 degrees on both sides. Has a little bit of restriction of knee to chest. He's about 105 degrees on the right, whereas he's 120 on the left. Hip rotation is real good. I don't implicate the hip joint itself. I screen the symphysis pubis. It's solid. I do note, and I hope you might be able to see this, but if you can visualize most of his body, when I do traction on his left leg and I let go, you can see that the body, you can see the integrity, and you can see the integrity of the movement. When I do that on the right side, you can immediately see a qualitative difference as though he's guarding on that side. Again, here's the left side. I'll do it repeatedly. And here's the right side. It's just not the same. And I can feel this. You may not be able to see it, but there's a little bit of delay in the recoil of that structure. I'll demonstrate that to you in a couple of different manners. Now, when we palpate the front of the pelvis, I've named this the anterior iliac shelf, which is the inch and a half portion. He's ticklish. The inch and a half portion of the pelvis that's right above the ASIS. It's fairly planar. So I call that the anterior iliac shelf. This one is lower. Okay, the right one is lower than the left. And when I do a spring test to create posterior rotation on the left, I can spring it and it recoils when I let go. On the right side, it's so different. It feels so qualitatively different. In fact, the movement does not produce rotation as it does on this side. Rather, I can feel the pelvis actually moving laterally. So it's distorting. The force that I put in should produce a posterior rotation, but it does not. So we know that something is not right. Lateral side glide of the pelvis is good. And let's have you now lie on your stomach, okay? All of his landmarks on the right side are inferior. I know you won't be able to see that with the camera, but his right PSIS is inferior, and it's also a little bit deeper than this side. Sacrum is symmetrical. The iliac shelf, another thing I've named a portion of the ilium that's fairly flat. I've named that the posterior iliac shelf, which gives me more information than chasing that elusive crest. And the research will bear that out, that the intertester and intertester reliability is better using the shelves versus the iliac crest. Anyway, the right posterior iliac shelf is inferior in relationship to the left. When I palpate the ischial tuberosity, it is significantly lower, and this I think you'll be able to see on the camera. You can see that this right side is inferior. Now the sacrotuberous ligament you can find if you just make a little triangle like that and just place it on his buttock, okay, buttocks, and down here in the middle of the lower portion, the gluteal crease, is the ischial tuberosity. And the sacrotuberous ligament goes from the sacrum, from the inferior portion of the sacrum, to that ischium. Now, there is nothing in here that is bony. So what I am on is the sacrotuberous ligament. And you can see that I can actually spring that structure, and it has a little bit of resiliency. It feels like nylon rope, 1/4 inch, 3/8 inch nylon rope that's somewhat tight. And you can depress it and it bounces back. On this side, I encounter it sooner. Okay? So this looks, you know, a little bit more posterior, and it feels very, very hard. It feels like bone, but there is no bone in this area. That is the ligament. And it's tight because this ilium has slid down, and therefore that ligament is being stretched constantly. Okay, I'm going to show you a superior spring test on the left. I can take up the slack, okay, and I'm maintaining this. I've taken the slack out of the structure, and I'm pushing with between 15 and 20 pounds of force. I'm not going to let go of the slack, but I'm going to repeatedly spring him, and you can see the body accept that force, and it bounces back. And now I'm going to let go. Okay, are you okay with that?
Yeah.
All right, I'm going to do the same thing over here, and immediately it's very obvious I cannot take up the slack in this structure. And so I increase the force, and I'm at about 20 pounds, and I'm at about 25 pounds of force, and I cannot take up the slack. I cannot create any movement on this side. Okay? I'm going to do an inferior spring test. And I'm going to do it on the non-affected side, his left side. So I have to locate that iliac shelf. And I take up the slack, okay? And you can see that I can spring it. Okay, are you okay with this?
That kind of hurt.
It hurts a little bit?
That did.
Are you all right?
Yeah, I'm fine. It's just.
Okay, I'm going to do the other side now. And I'm not able to take up the slack. And I'm definitely putting about 20 pounds, maybe more, and I cannot take up the slack. So I conclude that this side is stuck. And it's stuck with that hemipelvis being inferior. Okay? I want to take one more look at you in a different position. Could you get up on your hands and knees? And I'm going to want you to stay bent forward, stay on your hands, but I want you to sit on your heels.
I mean, like.
Just sit backwards onto your heels. Are you okay with this?
Yes.
So this is called child's pose in yoga. We also call it Muslim prayer position. And it's a very useful position. I would never not test someone in this. And I'm grateful to a friend, Rena Lubin, who's up in Alaska, and she taught me that many years ago, and I've never forgot it. It's been very, very rewarding to always screen in that position. And everything is maximally flexed. His lumbar spine is maximally flexed, as is thoracic spine. Pelvis is maximally flexed. Hips, knees are maximally flexed. So it really is the end range flexed position of the body. And I look at the pelvis in this position, and same findings of the right side being inferior. And then I come onto the sacrum, and position-wise it feels normal. I could do a spring test on the sacrum. He has good mobility there. Good mobility there. Okay, so can we have you lay back down on your stomach? Sometimes you'll find movement dysfunction, postural dysfunction in that position that you will not find in any other position. Now what I'm going to do now is test for a variant of upslip, downslip, which I've named oblique upslip and downslip. And you can see that on the left side I take up the slack, I can spring it, it moves, it recoils, and now I let go. Now if I cause pain, you need to tell me and I'll stop, okay?
Okay.
I know you're ticklish, so sometimes it's hard for me to discern between tickle versus pain. Okay, we're going to take up the slack now. It's pretty difficult. I think I take up the slack really early, very quickly, and now I try and spring it, and no, nothing happens. So it is stuck in that direction as well. I'm going to do the same thing inferiorly, try and take up the slack. No, can't do it, so I can't spring it either. Okay, so I think what we're going to do now is stop filming, and I'm going to then treat this, and then we will see if we make any difference in your ability to walk and such, okay? And we'll see if there's any difference in the mobility. So we can stop. Thanks.